Hi, uOttawa medical students, and welcome to an information session on COVID-19 with Dr. Vera Etches. Dr. Vera Etches is a public health and preventive medicine physician, as well as Ottawa Public Health's medical officer of health. We wanted to start the session off by thanking Dr. Etches for your time, as you are understandably very busy. And on behalf of medical students at uOttawa, we truly appreciate that you've taken the time out of your busy schedule to discuss with us and answer our classmates' questions. In terms of the structure of the session, Dr. Etches will start by providing us with an overview of the situation at hand regarding the pandemic. We will then follow up with students' questions that were not discussed during the presentation, and the session will be video recorded and subsequently distributed to medical students at uOttawa.
Okay, well, thank you. I really appreciate this opportunity because when I was a medical student, I didn't get to hear about public health until after my first 2 years out of a 4-year program. And yeah, it's sort of sometimes a specialty that you don't think of, but pretty hard to avoid us nowadays, unfortunately. The the response to the COVID-19 pandemic, I think about in a framework of kind of 4 areas of action. So if that's helpful for you to have an organizing kind of approach, I think about what we need to do to control the disease. So first of all, disease control. And that is a partnership. It's work done by public health as well as the healthcare sector. And I'll come back to that. And then there is the whole work around what we call non-pharmaceutical interventions. So non-pharmaceutical interventions, people sometimes call them public health measures, but it's those things that are like school closures, physical distancing, some of these other things that actually have never been implemented to the degree they're being implemented now, and have really potentially negative effects as well as the positive effects on the disease trajectories. And so that third area of work in the response is related to supporting society. So looking at beyond the health needs and the disease control, what can we do to mitigate some of those harms? So that would be around considering people's mental health, financial needs, social support needs, those kinds of things. And then the last thing that we all are looking forward to coming is a pharmaceutical intervention. So having drugs that work, antivirals, or a vaccine that would help us, really build immunity in the population. So I'll just go back into those 4 areas and just make a few more comments about the status of what's happening now. I will always use Ottawa as the example because that's what I know. I'm responsible as the medical officer of health for the city of Ottawa, all the residents, all the visitors, all the workers, people that come through our geographic jurisdiction. And so what I say is based out of that, although I can refer to what's happening in other places too. So on the disease control front, we have, to begin with, a need to identify the disease. So we need testing. And there's been limits. We'd like to be able to test anybody who could have COVID-19, who has a cough and a fever, never mind what their exposure history is. And we just aren't there yet. I'm hoping that we will build our capacity over time. And so the initial approach to testing has been to prioritize populations. Right now, we're in a time of prioritizing testing for healthcare workers, for essential services workers, for those who are confirmed contacts of cases, those who are in more vulnerable situations like a long-term care home or retirement home, and people who have traveled, who've maybe had that exposure history. There's no limit. We can go beyond that, and we're looking at that now as our lab capacity is growing, to look at being able to test family members of healthcare workers, because that makes a difference. To be able to test people whose symptoms are escalating. I probably should have also mentioned that we always test people who are hospitalized with any respiratory symptoms, and in an outbreak situation, anybody in that facility that has an outbreak who has symptoms. So that's one of the things. Once we have a test result, Ottawa Public Health follows up with that person to understand where they've been. And we call this case and contact management. And so this is a key public health role we do every day for lots of different diseases. And now our team, which is usually about 10 or 12 people, is up over 100 people. So we're continuing to grow that team as the need for follow-up with cases and contacts grows. I don't have the recent figures, but initially every case was leading to at least 16 contacts that needed follow-up, and that is, what we're trying to change, that people aren't out and about exposing others. But it's a challenge because people can be infectious in the 2 days prior to their understanding feeling ill, and so this is one of the real problems with COVID-19. The other thing we are doing is working with our healthcare system. So disease control means also being able to have the appropriate treatment for people, which is supportive. So there's no recommended antiviral right now, and so the work we're doing is to help the healthcare system ramp up their capacity for critical care beds, uh, looking at how we can increase our ventilator supply because the projections are there that show we'll need more capacity than we normally would have. And the healthcare system is doing a really good job actually of keeping people out of hospital who don't need to be there right now. The emergency room visits are below half of normal, and the people who might need an alternate level of care are being transferred out of hospital. There's a lot of work so that hospitals do have the capacity, we see, to be able to handle the volume till the end of April and looking beyond. So when it comes to the non-pharmaceutical interventions, we've seen those become more and more strong over time. Right now, there's an emergency order by the province that really is limiting the number of businesses that are open, looking at things like people not being able to go to parks, to like all kinds of events, gatherings of greater than 5 are now illegal, and the police have the power to enforce that. We can talk more if you're interested in some of the rationale, but the modeling shows that this will make a difference, and it actually is making a difference. That we would expect the rise in cases to be much greater right now if we didn't have these measures in place. So when it comes to supporting society, I can tell you part of the public health work of thinking about what do we need to do to respond is to think about the ethics of our actions. And so one of the things you get taught in medical schools, do no harm, right? And so these public health measures are doing harm. There's no question, and on a large scale and involuntary. Typically in public health, we try to hold ourselves to a really high standard of doing no harm because it's involuntary, and the burden here shifts in terms of it's more like not withholding a treatment that could save lives. So we know that the public health measures that have been implemented, while they do harm, they are saving lives. And so the ethical burden becomes to mitigate that harm and not withhold that from the population. So back to the pharmaceutical interventions, I just want to say the drugs are being studied. Don't know when that will help us. The vaccine, on trying to create a vaccine, which will be key. So that's the framework of the response, and I think I'm happy to focus more time on questions in terms of where you have thoughts. I'm happy to address them.
Okay, so Dr. Etches, thank you so much for that incredibly informative presentation and talking about the 4 pillars of the public health approach. We have a number of questions submitted by students, so we put them in order of priority. We realize your time is very valuable, and so we're going to try to get through them all, but if we don't, we have them in order here. First of all, how long do you believe the pandemic will last, and when do you think it will peak and resolve?
Yeah. So we'll be able to see the waves of infection in our community decrease when we have greater immunity, and that is going to depend on how much of the population is exposed, and or if we get to a vaccine. So there are a number of models that are showing that while we're having success with physical distancing suppressing the infections in our community, it really is only a suppression, and the risk of an increase, another wave of illness, say, is always there until the population is more immune, and that could go on for 18 months if that's how long it takes for a vaccine. In terms of the peaks that we're seeing over that period of time, it will depend on how much people are adhering to physical distancing. And so it's really up to individuals in different areas, different countries, to change that slope of the curve and when the peak occurs. So it's very difficult for me to predict exactly when that will be. What we're looking for is a decrease in the infections that are counted, but the testing that we have is so limited that it's not a perfect picture. So we have to use the test that we've done as a data point in terms of the infection in our community, but it's not perfect, and so it's not perfect for modeling also when things will peak. Hospitalizations are harder to hide. Most people with severe illness will end up being hospitalized, and so that's a more robust indicator to follow, as well as death. But those are also indicators that lag. So when somebody is hospitalized or dies, that's usually a good 4 weeks from when they were exposed, because of the incubation period, because of the time it takes to develop severe illness. And so that if you're looking at that data, it's reflecting what happened a month ago. And so it really does take time to be able to understand what measures are having an impact. So I think in terms of when this will be over, we all want to ease up on the physical distancing measures as soon as it is safe. And by safe, I mean we can be assured that the healthcare system can manage the capacity that it's going to be facing. And so I think rather than anticipating that this is going to be over and we'll go back to normal activities, this is going to be a months-long duration of calibrating how much freedom we have, how much we can resume normal activities based on how our healthcare system is functioning and has the capacity to handle the rates of illness. And those questions are being considered now, how to do that in a way that's ethical, who deserves to have freedom first, who needs to be considered in terms of more vulnerable populations, people whose economic situation is more dire. There are a lot of things being considered around trying to move away from the physical distancing as soon as we can.
Thank you. And one of the questions is when we're able to confidently say we flatten the curve, and you mentioned when the healthcare system can handle sort of COVID cases. Would you say that matches when you would say that we have successfully flattened the curve, or is that a different answer?
They're different because we may see flattening of the curve in terms of the number of cases or the hospitalizations or deaths I mentioned that are more reliable information. But we still may not be able to ease up on the physical distancing if the healthcare system can't handle a rise in infections again. Because we know as soon as we ease up, there's that population that's still not immune and the cases will go up. So I think they're related questions but different. The other thing that needs to be in place for safety in terms of easing up on physical distancing is the capacity to do more of the case and contact management. So if we're going to say we're not all protecting each other by doing our part with physical distancing, then we need to be able to find the cases and do the contact tracing in a more complete way than we're able to right now, given the lack of testing and the way we're scaling up our teams to do that work. Maybe it's a good time to say that medical students who want to be involved in that work of case and contact management can apply for a research assistant position. There's a job posting right now on the City of Ottawa website for research assistants to work with Ottawa Public Health, and that is the work of case and contact management that we need to do. So it's a casual employee role where people can work the hours that they're able to work. But we are interested in that, and I think it's a nice way for medical students to get a better understanding of this public health work. So I think that this discussion of exit strategy, has some of these pieces that need to be in place: health system capacity, case and contact management, the testing that drives that, as well as attention to the economy and what do we need to start up first. Different countries are doing different things, and there's no strong evidence about how to do this yet. We'll be studying it as we go and thinking about questions like, do schools reopen first? What kind of industry is important to support first? Those kinds of things.
Thank you. And what would you say the estimate of is the proportion of people that have the virus but are not showing symptoms?
Yeah, one of the challenges with COVID-19 is that we're learning there are many people who are infected that don't have symptoms. Some studies suggest that could be as high as 25% of people infected don't have symptoms. It still doesn't tell us, that's been done, where people have tested a whole population. It still doesn't tell us how much are those people who don't have symptoms infecting others. That's not clear how infectious you are when you don't have symptoms, because like all respiratory viruses, you have to spread your snot and your respiratory secretions around to be able to infect others. And that is still more likely for people who have symptoms, right? You're coughing, you're spreading more virus. I would say that the infected population that's probably contributing more to spread are those people who are building up that reaction, but in the 48-hour period before they feel ill. That seems to be also now a period where we're seeing there can be transmission 48 hours before people recognize they're ill. And it's a challenge, there's no question. That's why the physical distancing is really helpful. Basically, we're telling people you need to assume it could be you or your neighbor. It could be anybody, because we don't know if they're in the process of becoming more infectious or not.
And on that topic, one of the questions we have is whether COVID-19 remains on clothing, on grocery bags, on things like that. What have you found in that regard?
We're still learning. I would say the science isn't definitive on how long COVID can remain on surfaces and clothing. There are some suggestions that it can last days on very smooth surfaces in the best kind of environment, but cloth surfaces, rough, porous surfaces, it's unlikely that it survives longer than a day.
And in terms of, you talk about a lot of the data public health is gathering and the work that you've been doing, and I understand that involves modeling. And for someone like me who doesn't have a great appreciation of what modeling is, could you explain how Ottawa Public Health applies that modeling and how it has been used to estimate the number of cases of COVID?
Yeah, it's really interesting work. The workforce in a public health organization includes epidemiologists, and actually our training as public health specialists includes epidemiology and statistics, so we can be informed about how we measure the health of the whole population, and so some of those tools are coming into play. The modelers in this case are people based more in academic institutions like the University of Toronto, and then they're partnering with our epidemiologists to be able to try to calibrate their models. So the initial models were built off of H1N1 influenza pandemic in 2009, and they take into account many different variables in terms of how likely is one infection to give rise to others. In this case, we know one typically is giving rise to 2 or 3 others. They look at, the incubation period. They build that all into the model to think about different populations that are at risk, based on different ages. How likely is someone to die and then they're removed from the population that's potentially immune? So there are a lot of things that get put into play, and you can get estimates for these different variables from the literature, from observations that are being made, and then you project what's happening. And so that is the kind of thing that we were using in the early days to say that there's community spread. When we see some cases, we know that there are others that have been missed because not everyone's being tested. Not everyone thinks it's COVID-19 and presents. And so then we can estimate how those cases that were missed lead to more in the community. There are many different ways of looking at the modeling now, and the problem is that we actually need to calibrate with real data. Where are we? So the models can give us a curve. They're very useful for understanding that curve of infection in the community and how that might change if we do different interventions. So that's where they can say, what if we closed all the schools, and they take out the transmission among children in the model, and they see what happens, and it's great. The curve really flattens. They say, what if everyone, who could works from home, and they look at the decreased transmission among adults, and you can see the impact. So models are good for that. But to figure out where we are, they need to try to have a real count of cases in the community. And so that's harder because we're not, due to our limited testing capacity, able to do a lot of population survey of just a random sample of people out there and test them and see what's happening. But that's where other models come into play that can use the more reliable data like death and work backwards. So you have people out of the London School of Hygiene and Tropical Medicine that have created a model. It's there for medical students to take a look at, that you can enter in the number of deaths and then work backwards to think about how many infections does that mean you might have in your community, given the likelihood of that outcome. So there are a few different ways to look at it. None of the models are perfect, but they can be useful.
So one thing I have to ask about is Ontario medical schools are currently projecting a July 6th return date for their third-year clerkship students. They're currently out of the hospital right now. They had been in the hospital before, but were told to stop their clinical placements. We were wondering, did public health have a role in this decision, as well as a role in setting the date of July 6th? And also what maybe your professional opinion is on third-year clerkship students not being in the hospital at this time?
As far as I know, certainly Ottawa Public Health wasn't consulted about the university decisions around students being in clinical settings. I know the universities all across, and all university students are being asked to find mobile ways of virtual ways of connecting so that there's fewer people gathering, because that gathering is an increased risk of transmission. And I'm assuming, I don't know, but I'm assuming that the university decision to not have medical students in clinical roles is to protect students because of the risk of transmission of COVID-19 in clinical settings. We are seeing that happen. We have 2 hospitals right now with an outbreak declared, third hospital with many healthcare workers infected, looking for a link. There's no question that being a healthcare worker puts you at greater risk of infection. And I think the universities have, to protect students. So I imagine this is part of their thinking. In terms of choosing a date, you have to choose a date. I think we've just seen people extend in Toronto and Ottawa, other places, this canceling of all mass gatherings and, other kinds of programming that would bring people together until the end of June. And probably we'll have to look at that again in terms of an extension. So I think that based on what I was saying earlier, we don't have a population that's immune. there's going to be an ongoing risk if we ease up on the physical distancing too quickly of a surge in infections that could overwhelm our healthcare system again. And so it's going to be, an ongoing conversation. We can't give a definitive answer past July 6th, but we need to keep reviewing where we're at.
And then in your opinion, do you think medical students should be allowed back into the hospital sooner, or do you think that they are doing more good by staying out of the hospital and engaging in things like community volunteering?
I can tell you there is a lot of need in the community, and so it's certainly very, very heartwarming to see that medical students are helping people, for instance, who are having to practice self-isolation. There are volunteer portals that medical students could access to be able to indicate they're willing to help. The Volunteer Ottawa is for the City of Ottawa, and that really is about meeting those needs of more vulnerable populations. And then there's a portal that is federal for healthcare workers, and I think you could indicate as medical students you have some knowledge to contribute as a future healthcare worker, as a healthcare worker in training. And so that pool of volunteers is being accessed by public health units across the country, I think, who need help around some of the other functions like case and contact management. And again, people are welcome to apply for that work if they have the capacity, since they're not working clinically. So I think it's an opportunity to learn about new things, to explore some of the other things that make people healthy or not, in addition to the clinical care.
Thank you. With Ottawa Public Health, you described a lot of the work you're doing and in consultation, for example, the modeling with University of Toronto, University in London, and we were wondering, in terms of the different levels of government, for example, like the federal government, provincial government, and the hospitals, the Ottawa Hospital and Ottawa Public Health. Can you describe the interplay and how your agencies work together to tackle the COVID-19 response? Like what these collaborations might look like?
Yes, and I think it is important also for medical students to know their career options in public health also span these different levels of government. So federally, our Chief Public Health Officer for Canada has a role to play in terms of reporting internationally to the World Health Organization and having access to what's happening internationally. And then she's leading scientific advisory committees, technical committees that help bring all of the provinces together to access the latest evidence to inform their approaches. At the provincial level, our Chief Medical Officer of Health and other physician public health specialists there are then responsible for the response within the province, and they have powers under Health Protection and Promotion Act in Ontario or similar to actually be able to issue directives when it comes to the control of an infectious disease. And we've seen that directives related to keeping track of PPE or how PPE should be used. For instance, PPE is, of course, personal protective equipment. The local level, that's what I'm doing, is I'm working for a city area, and we have also those connections back. So we have regular ways we connect in with the province and can share information in both directions. Most of my time is spent collaborating with people at the local level. So this response requires connections with the healthcare system, and usually hospital leaders are the lead, as well as drawing in a network that crosses all the different players in the healthcare system. So we have an emergency response structure in place, and I'm happy to speak about that more, but it's one of the things I hope medical students are learning more about is an emergency response approach. But they're more streamlined for faster decision making, more top-down streamlined processes. And sometimes when we have more time, we have very collaborative and consensus-based approaches, which is great, but you don't have time for that in an emergency. So the hospital, then leads a network that includes long-term care, primary care, retirement homes, palliative care, mental health agencies. All of these folks are connected in. And we advise the healthcare sector as public health people on infection prevention and control, on how to address outbreaks in their facilities. And so there's a planning function that we're working together to look into the future together about what's needed. Some of that surveillance, the monitoring what's happening and reporting we do together. And then the third party that's really a lead in this response at the local level is the city. So the city of Ottawa has the lead on addressing more of those human needs, we call it, so the social needs, the economic crisis that people are facing, as well as maintaining essential infrastructure that's needed to run a city. And so there are daily connections between those parties at different levels. And I think that myself, personally, I'll also indicate I, as a public health physician, have a role in being a spokesperson. I think you see that at the different levels, federally, provincially, locally, as well as thinking ahead. So my role is to try to stay at a strategic level and to think about, even how do we get out of this? How do we recover? The other public health physicians that work with me at the local level, they are the ones that are doing the work of, providing evidence to inform specific decisions around cases or contacts. What counts as an exposure? What should I do in this situation? So we have physicians who are consultants and who are keeping up to date on the evidence. So maybe that's a little bit about the different public health roles, and I'm happy to expand on anything that wasn't answering your question enough.
I think that was a really good overview. Thank you. And on the topic of sort of things that may be coming through at the federal level, and we're interested in what Ottawa Public Health's position will be, we saw recently that the CDC recommended the American public wear non-medical masks. And we're wondering if Ottawa Public Health is considering a universal masking policy seen in other countries like Taiwan or Singapore. And in addition to masks, things like people wearing gloves or medical PPE out in public.
Yeah, absolutely something that's been on our minds for a while. The evidence about mask use in a pandemic is limited. And I think early on in the pandemic, what you heard us talking about was addressing people's fear and concern and desire to wear a mask so that they wouldn't get infected. And it is problematic if people are wearing a non-medical mask that's not fit tested. It doesn't remove the risk of becoming infected like it would in a hospital setting where someone's fit tested and they have the appropriate training to take on and off personal protective equipment. And so we were cautious, telling people that isn't a guarantee and can't protect you against infection and can cause a false sense of security. At the same time, early on and now, we are saying you should wear a mask when you are infectious, when you're sick. And so if obviously people are supposed to be self-isolating when they're sick and staying home, but if they need to go out to get medical care, they need to be wearing a mask, has been our messaging. So this now is an extension, the change to say that there is room for use of non-medical masks when you're going out, even if you don't know you're sick, because we know that there's this asymptomatic or this early infection period where you could be infectious to others. And so it's another layer of protection. There's still problems with wearing masks, non-medical masks where people aren't trained and fit tested. And so we need to make sure people do it safely in terms of washing their hands before they put on the mask, wearing something that's fitted appropriately, making sure they wash them and wash their hands when they take them off. So we have some of that guidance, on our website. The key is to still keep the physical distancing in place because the masks aren't going to be perfect, and it's really that staying away from others that prevents the respiratory droplets from landing landing on you and causing transmission that is most important. I think really the concern about messaging too strongly on masks early on and still now is that the supply of medical masks is limited. It's limited worldwide, and we need to make sure that medical masks are used for healthcare workers. So we don't want to divert any of the supply, which is not sufficient even now. When it comes to other things like gloves, still not recommended. They're things that can become contaminated. Like the most important thing is to wash your hands and keep your hands clean. And if your hands aren't clean, to not touch your face, your eyes, your nose, your mouth, to introduce infection. And so again, message this to the public. People may choose to wear gloves, so then we have messaging on how to do that safely.
And on the topic of PPE, we've heard different things from healthcare workers and from the province, and we're wondering, is there a shortage of PPE for medical workers in Ottawa and Canada, to your knowledge?
There is, in terms of, people would love to have a clear supply, an ongoing quantity that they can count on and plan around, and that's just not in place. And people have heard there are masks coming, and there will be, but it's hard to have a predictable supply at this point in time. I think we're going to see industry pivot and try to produce more of these products within Canada, and that will help over the longer run. But we're still not there yet.
And certainly you mentioned about people wearing masks if they are infectious, and we've heard about different terms like self-quarantine, self-isolation, physical distancing, and we're wondering maybe if you could give an example of what the differences are, and also how is it being enforced if someone is infectious with COVID-19 and they're being told that they have to self-isolate. How is that being enforced?
Good question. I will take a moment to just talk about specifically what quarantine is, because it does get mixed up with isolation. Quarantine is for people who have potentially been exposed to an infectious agent and who may be infected, could be incubating, and then will become infectious. And so they're being asked to stay apart so that they don't pass on that infection to others when they become infectious. And the terminology that's been introduced in this response is a little confusing because we've used new things like self-quarantine. Self-quarantine probably was chosen because it spoke to the voluntary nature of that for people that were returning travelers to Canada. Now we have an order, a federal order under the Quarantine Act, that people who are returning to Canada must be under quarantine. And I think this is where sometimes the self-isolation term is used, which is not technically correct. And it's being used, it's out there. So, you can always check ottawapublichealth.ca to know what you should do under certain circumstances. But the Quarantine Act allows police powers to be used to maintain that requirement. And so in Ottawa and in other places, it is the police who will enforce the Quarantine Act. Self-isolation is different. That's used when somebody is infectious. We know they're infected. We know they could pass the infection on. And so we say you must stay apart from others so that you don't pass your infection on. And that is for people who have confirmed COVID-19 or people who we think could have confirmed COVID-19. It's not confirmed, but they could be, who meet a clinical definition, for instance, or who've been a contact of somebody who is a confirmed case, and we assume it's COVID-19. We actually ask anybody who's sick with a respiratory infection to self-isolate because it just is the right thing to do, not to pass on your illness. And something culturally I think we really, really want medical students to absorb. We are seeing healthcare workers work while they are sick. It's happening over and over again in this outbreak, and it's not helping. So stay home when you're sick. How can that be enforced? We usually use a voluntary approach. It's very rare that we need to do an order. under the Health Protection and Promotion Act, but it can be done. So very rarely in our usual practice would we have to order someone. It's an ethical principle of public health practice to use the least restrictive means. And so that means education. It means understanding why somebody might have difficulty self-isolating. People may not have groceries. They may feel they have to visit their grandmother, or there are things that we don't always know that are going to maybe drive people to not self-isolate. And so our public health nurses look into this when they're talking with a case. They explore, do you have what you need to be able to self-isolate? And it's part of the work of the city and the Human Needs Task Force to be able to get groceries and food and essentials to people who need to be self-isolating. And it's one of the areas that medical students could help out with. So that, if more enforcement was needed, and we're not seeing a problem with that so far here in Ottawa, something could be done like was done in Toronto recently, where the medical officer of health issued a class order. So it was for anybody who's a case of COVID-19 or a contact of COVID-19 must self-isolate. And that then lays the groundwork for a court order and enforcement under the police to be able to do that. So the class order under the Health Protection and Promotion Act is an option. Not to be too technical, but to go into it, if there are some downsides in terms of the effort that it takes to actually get the ability to enforce that order. You have to go to court and ensure that a judge upholds your order, deems that it's necessary to control an infectious disease, that there's an imminent risk of harm, and then once the court upholds your order and that's broken, then the police can step in and take action as well to uphold the order. So the best way to get people to comply is to help people understand the rationale for why we are asking them to self-isolate. And the vast majority of people will understand that this is to protect others and will do it.
And in terms of length of time for self-isolation, is it 14 days from the onset of symptoms, 48 hours after symptoms are resolved? I imagine Ottawa Public Health website has advice on that. Do you have easy advice to give, or is it case by case?
That's exactly it, and that's based on what we know about how long the virus remains infectious in people. So it's a conservative figure. There are some studies showing that the virus 8 days after symptoms is no longer viable, even if it's detected. But that's limited evidence, and so the 14 days after onset of symptoms is chosen as a protective period, or 24 hours after the symptoms resolve, whichever is longer.
One of the questions that was submitted, it starts off that homelessness, as you know, impairs a person's ability to follow public health advice such as physical distancing, self-isolation, performing proper hand hygiene, and moreover, people experiencing homelessness are much more likely to live in conditions that make them at high risk of contracting and spreading the coronavirus, such as crowded housing, interacting with a variety of people on the streets, and etc. So what has been done by Ottawa Public Health so far to specifically address the unique needs of the homeless population in Ottawa?
I'm really pleased to hear medical students asking about this because I do think it's a test of our society in terms of how we treat the most vulnerable people in times of stress. And absolutely, it's not fair to ask someone to self-isolate and stay home if they don't have a home. And so I'm pleased in the city of Ottawa that the very first new facility that was opened in this response was a facility for people who are homeless to self-isolate if they develop respiratory symptoms. And there are other things that have been done, again, by the city of Ottawa to protect the population that is underhoused. For example, finding accommodation for families so that they can stay more, in areas with less risk. And that's continuing. People are continuing to look at ways to decrease the risk. And Ottawa Public Health always has a relationship with shelters around infection prevention and control, and trying to help with strategies that can protect that population, which is at higher risk for an outbreak.
Regarding COVID-19 in general, we've heard talks of potentially second and third waves of the coronavirus, and we've heard of the possibility that we are not flattening the curve. What do you think the reality of these possible larger waves or future waves of coronavirus affecting us again are happening? And what are our next steps for addressing COVID-19?
Yeah, so I think we touched on this a little bit earlier, that as soon as we ease up on the physical distancing, because there is still COVID in the community undetected, and because we have a population that's not sufficiently immune enough yet, we would expect to see an increase in cases again, so another wave, absolutely. And so the focus is right now on how to build capacity in our healthcare system to handle that if we continue to get more cases, and on building public health capacity for testing and contact and management, case and contact finding and management, so we can be more precise in our approach to controlling the disease. There are people thinking right now about the recovery strategy on the economic front as well, and thinking about the different measures we could sort of titrate or calibrate, easing off some of the physical distancing versus everyone returning to business as normal. I actually think what's also important is changing how we do our normal business. I'm pretty sure as medical students that your education may become more virtual in the future, just given this experience. And that is probably what we'll see across different sectors, across business and schools and universities and others. So it's finding these new ways, and it will decrease the risk of transmission as we ease up on physical distancing. That's some of the priority work right now.
Thank you, Dr. Etches. Do you have a high-yield reading list of references for medical students to check out regarding strategic thinking, public health response, pandemics, that sort of thing?
I can send some ideas later. There are frameworks, again, for pandemic plans. They're typically based around influenza, the most common organism that would cause a pandemic. And so they're useful to understand what are the considerations in a pandemic plan. I think there are some good news outlets actually that are providing excellent comparative graphs across the world. The New York Times doing a fabulous job sharing some of the things that are being learned about this response. And I think what I would want to convey on this is that, in fact, we are in uncharted territory as well. So the frameworks are helpful. They are useful, but we also have to just be flexible and learning in the moment as we go forward. That the data sources we have are imperfect, the evidence we have is imperfect, but we have to be able to see the challenges in some of our data, and then still make decisions and be open to be able to say, I was wrong about that, or we have better evidence now and we're going to do this. One of the key roles of public health physician is to communicate what we know, what's important for people to protect themselves and to protect others. And sometimes it's what we don't know, but we need to be able to be transparent. I would say one thing I think medical students often don't learn very much about is called risk communication. And it's really useful. People look to physicians as communicators, as sources of information, and knowing how to talk about a crisis and convey information is a really key skill for medical students. So I would recommend Peter Sandman. He has a website that is full of good ideas about risk communication. And so, I think that the other thing I'm doing that isn't in a book anywhere, it's not something that the plans tell you to do, but I would recommend, and maybe it's relevant always for us to keep learning, is trying to bring together people who have different perspectives than yourself, from different sectors. So I have a group I'm calling my thought leaders table, people from senior levels of government, from the university, from business leaders, from communications and public relations field, from the military, people who are going to bring their experience from different sectors, from the nonprofit sector, to inform the response, to make sure I'm not missing something, that I'm thinking of things that might affect others where I wouldn't normally necessarily think of that. So that's part of trying to go into uncharted territory, is not going alone, thinking about what can others bring to inform the response. So I'll follow up afterwards with some other references, but I hope this has been